Hello. In this presentation today, we will be discussing the clinical uses of transesophageal echocardiography as a monitoring tool during high-risk non-cardiac surgery. Transesophageal echocardiography is a very popular hemodynamic monitor, both during cardiac surgery as well as high-risk non-cardiac surgery, for a multitude of reasons. Most important being that it is minimally invasive. The patient just has to swallow the TE probe. It generates high-resolution images of the heart, displays dynamic anatomy, and most importantly, we'll get to it, is anatomy with a physiological perspective. There's a lot more that we can get from transesophageal echo than the structural information that we shall discuss in a second. However, the historical paradox of transesophageal echo is that the initial use of transesophageal echo was for assessment of wall motion abnormalities during vascular surgery for ischemia monitoring. And the use of transesophageal echo for non-cardiac surgery actually preceded the use for its cardiac surgical application. So that's the historical paradox. Historically, the first time transesophageal echo was used in 1976 in University of California, San Francisco, but the use was quickly abandoned because of the size of the probe, and it was used for only those patients who had suboptimal transthoracic images. Then 4 years later, in Albert Einstein College of Medicine in New York, there was an epicardial stethoscope that was used for M-mode assessment of the left ventricle, which was later converted into an esophageal stethoscope to avoid interruption of surgery during the process and get high-resolution images of the heart. So that's how it started initially as an alternative to transthoracic echo, and secondly, to monitor ventricular function during cardiac surgery through the esophageal route. However, later on, it was decided to use the transesophageal echo in perspective of the high-risk condition of the patient, the high-risk nature of the procedure, and the context of the circumstances, because of being emergent and urgent, leading to the use of transesophageal echocardiography to provide not only diagnosis but also monitoring as well as continuous response to therapy. So what has been established so far, that is, it has two category 1 indications, that is, when there is indisputable evidence of its clinical use. Number one is life-threatening hypoxia by excluding massive intracardiac shunts, and secondly, life-threatening hemodynamic instability, which is unresponsive to therapy. And the major reason for this effect and this impact of transesophageal echo is that it helps in a rapid establishment of diagnosis, institution, and following the response to therapy in real time, as we shall discuss in this subsequent section. This is not an uncommon scenario in the operating room. When the patient presents with hypotension, hypoxia, is unresponsive and resistant to therapy. Now, this is an identical presentation for variations of clinical situations. And not that we cannot figure them out, but we need a very rapid and precise diagnosis to guide a procedure-specific therapy. For example, this patient in the video at the top has pulmonary embolism and biventricular dysfunction, as opposed to the patient in the bottom video has a ruptured papillary muscle and needs a quick trip to the cardiac operating room, whereas the patient at the top video requires heparin and inotropic therapy. But the presentation is exactly the same: hypoxia, shock, and resistance to therapy. This patient above has a massive pericardial effusion and pericardial tamponade and needs that drained emergently, either in the cath lab or the operating room. Whereas the patient at the bottom has a classic sign of pulmonary embolism that consists of dilated and hypokinetic right ventricle with a hyperdynamic left ventricle. Response, again, from the team should be to give patient epinephrine, heparin, and continue with the CPR. The patient in the video at the top has dynamic LVOT obstruction because of systolic anterior motion of the mitral valve. Now, this patient needs to discontinue their inotropes, slow them down, give them fluids, and increase the vasopressor therapy to increase their afterload. This is exactly what the patient does not need in the bottom, who has severe systolic dysfunction. Now, this patient needs inotrope. This needs to have the afterload reduced and the fluids restricted so that the heart can pump better and not continue to have mitral regurgitation and back pressure into the pulmonary veins and causing pulmonary edema. The patient again on the top has severe right ventricular dysfunction with the septum moving on to the left side to the point that even the medications given during resuscitation are not going to the left side because we don't see any contrast medium on the left side. This patient needs CPR. The patient at the bottom has pulmonary embolism with a paradoxical embolism going from the right to left side, needing a completely different therapy. Now, this is a very important point to appreciate because the presentation to the operating room of these patients is exactly the same. Not that the team wouldn't eventually figure it out, but having an image-guided therapy which gives you a very precise diagnosis within about 10 seconds of acquiring this image makes the therapy very timely, increases the chance of survival and a better outcome, and that's where point of care or rescue transesophageal echocardiography comes into place. Well, these were the emergency uses of transesophageal echocardiography during non-cardiac surgery for which it has indisputable evidence. So let's discuss the role of transesophageal echocardiography as a monitoring tool or as a procedural adjunct or as a tool to follow response to therapy in patients who are undergoing high-risk non-cardiac surgery. Well, now that role is not as well established as that for acute emergencies. However, one of the most important things for transesophageal echocardiography, its use as a hemodynamic monitor. We traditionally use the pulmonary artery catheter to measure intracardiac chamber pressures, measure the systemic vascular resistance, the pulmonary vascular resistance. But little is known, but TE is a very established physiological monitor. Also, a lot of people call it as a PA catheter in a box, so which just goes through the esophagus but gives almost essentially the same information. So to put it all together, the category 1 indications of transesophageal echo are, where there's established role of TE, is in life-threatening hypoxia and hemodynamic instability. The category 2 indications, that's role is not well established and there are possible reasons and possible indications of its use are a multitude of them and depend on the training of the provider and the equipment availability. These are the two major determining factors of use in category 2 indications. Now let's get to the category 2 indications according to the practice guidelines by the American Society of Anesthesiologists. There's a little paradox over here one more time, because for both cardiac surgery, for its use routinely and almost a standard of care, as well as non-cardiac surgery, the level of evidence of use of TEE is B2 and B3, which implies there are observational studies, there's non-comparative observational studies, as well as observational studies with inconsistent results. However, based on evaluation of this evidence for both cardiac as well as non-cardiac surgery, the member of the expert opinion for cardiac surgery was that they think that the transesophageal echocardiography should be performed as a routine monitor. However, based on the same evidence, they said the transesophageal echo may be performed in high-risk non-cardiac surgery. So there's a little bit of paradox, possibly because there are more people trained in the cardiac arena in using transesophageal echo as opposed to the one in the non-cardiac surgery arena. Another one of the most important studies performed by Dr. Suryani and was published in the Journal of Cardiothoracic and Vascular Anesthesia, where they defined the major, minor, and limited impact of transesophageal echo, which was based on a retrospective analysis, and they found that it does have a significant impact, almost about 48% minor impact, about 17% of limited impact, and about 15% major impact, which implied life-threatening complications were diagnosed. There's an alteration in surgical management or the therapeutic management of the patient in the operating room, or the case was canceled for an additional follow-up based on what they found in transesophageal echo. So based on these findings on the utility of transesophageal echo in non-cardiac surgery, the National Board of Echocardiography has started the basic perioperative transesophageal echocardiographic examination, which has its own certification. However, the difference from advanced certification is that it is limited to non-diagnostic use, and the goal is monitoring and not diagnostic. In non-cardiac surgery, when transesophageal echo is performed, it is not to diagnose cardiac abnormalities, but to monitor the patient hemodynamically and follow response to therapy, and the diagnosis has to be confirmed with a more experienced and more advanced echocardiographer who is trained in the use of transesophageal echo. So in the final analysis, transesophageal echocardiography is a vital procedural adjunct for management of patients undergoing high-risk non-cardiac surgery, and those anesthesiologists involved in the care of such patients should have at least basic knowledge of the use of transesophageal echo for life-threatening complications. This is a review article on the use of transesophageal echocardiography and the available evidence in various surgeries that was published in Seminars of Thoracic and Cardiovascular Anesthesia and would be a valuable resource. Thank you and enjoy.